Good afternoon, ladies and gentlemen. Thank you, Dr. Suvira, for this opportunity. Um, According to me, during IA, I get maximum post-capsule rupture. How many of you feel that you will get similar post-capsule rupture during IA? One is because I am very relaxed. Nucleus is gone, so no nucleus drop. So I will relax. Second thing is there is gross mismatch between irrigation and aspiration, especially in bimanual IAs. And when we do large volumes, we get different types of irrigation aspiration systems. We don't know which is 22, which is 23, which is 20. So there is mismatch and there is surge. So these are the ones which you should make sure. And then IOL implantation again, especially when you're implanting Indian made IOLs. And I have nothing against India or Indian made IOLs, but then uh, when you have inconsistent uh, structure of cartridges, injection nozzles, then you end up in problems. And so let's go in detail into these. Managing no financial interest in having PC rent in during IA. What PC rent during IA? So see, this is IA. Looks so inviting and nice, So generally nowadays I put viscoelastic before doing it. That is, once my resident is asking, why do you put viscoelastic unnecessarily? I said, anyway, nurse is waiting. She is changing the handpiece. It is taking time. Why should I wait? I'll just put some viscoelastic and look at it and all. But anyway, many times the chamber shallows when you are getting. So I don't want the chamber to shallow, one thing. Second thing is, if the bag is inflated, you can approach the most difficult area. Especially I am trained in coaxial IA, so I use coaxial IA. There are many advantages for that, although the other one is also fine. I have nothing against it. So I go sub-incisional first. When I go sub-incisional first, when the bag is full, this is not such a one, but then generally I do that. So when the bag is full, the PC is very far back. I can firmly turn my tip down facing the PC. It doesn't aspirate the PC much. And again, as Shale can realize, they had a video showing that it's a clean sweep. You should sweep it from the equator, bring it to the center. So I am aspirating from the equator. That's not a great idea. Now I am aspirating from the PC, and see, I'm going and nudging at the PC now. I just held the PC, if you had seen very carefully. Somebody is looking very surprised. Please look again. I caught the PC just like that there. So if you do not sweep each layer of cortex and finish off from the posterior capsule, you will have pieces sticking onto the posterior capsule, and you will have to face the tip down and aspirate and catch. And now I do this flushing. Flushing is relatively safe for me now, rather than going in the whatever aspiration mode of 10 or 20. Still, many capsules of old people, the zonules are not very strong, and the capsules are low lax. Even 10 it may catch, and the vacuum may pull, and you'll see folds radiating. But if they are very taut ones, young ones, immature ones, nothing will happen, even if you have a 20 vacuum and sweep over the capsule. But this one seems to be very, even if I touch the capsule with these kind of round tipped cannulae, nothing happens. So flushing will help me get all these fibers out. I like clean capsules. So once this is done, we try to introduce the IOL. See, I have done nothing wrong. IOL is going in clean. The bag was fine. And just after implanting very nicely and trying to aspirate the cortex, I aspirate from behind also. See the viscoelastic. Now I see two lines on the capsule there. So if you notice very carefully, why have you switched on this light so bright? Yeah,
That's
think
the
this
problem.
is also
All these
can't
ones
switch
have
it off.
this.
See those two lines there. So people can consider that as a posterior capsule, but this is a strand of cortex. So you may get misled by folds, but folds which do not change their shape even while slight manipulation of the IOL should be considered as posterior capsule. But otherwise, if you manipulate a little and they are changing shape and budging and moving and all those, then they are cortex only. So don't be scared of all the folds, but always look out for folds on the capsule. See, like this. So if you have a capsule held like this, now you can just release your foot pedal. But if you release the foot pedal, sometimes it doesn't go off. Then you should know where the reflex button is. So reflex button, then only we'll remember that there is something called reflex, and you'll ask nurse, where is the reflex button? Up, left, or right, or where should I, what should I? So please use and make sure that it is always at one position. If you're using multiple rooms, multiple machines, you don't know which machine you're using, somebody else's setting will be there. So always initially itself, just make sure where the reflex button is. So that is in a good enough. See, that's what I Just wanted to show that once you have held, even if you leave the foot pedal off, now it is fully off, still it is not going off. So now you can see at bottom of this one, the reflex button. So the reflex button, if you hit, it will go off. The more you pull and the vacuum will generate and pull, then only it will break. Most of the capsules, just like that, when held, do not break. So this is a posterior capsule being nudged, and whatever you do to pull out the small fibers, you get a small opening there, and you get scared and withdraw the whole thing. So then chamber shallows, the opening becomes larger here, and it becomes full from one end to the other. So whenever you get an opening, do not be scared. Don't irrigate. Don't take out the irrigation. Put in viscoelastic, form the chamber, and then only take out. So like that, I did it for this case. There was a small opening here. If you see in here, small opening, very nice. So I just put viscoelastic, and so many air bubbles came from viscoelastics. I hate air bubbles, so I thought we should take all the air bubbles out and put more viscoelastic. So I'm hyperinflating, and see what happened. It opened up into a full thing. So when there are pointed edges, hyperinflating and lowering, shallowing the chamber, both can increase the size of a posterior capsule rupture. So don't overinflate, thinking that your visco is a great friend, then you keep on putting more, it will be nice and all. So if you dislike air bubbles, take them out so that there is some leakage also. If you put sodium hyaluronate right into the posterior capsule, it can push on the posterior capsule drastically. So that is why, with the help of Epsilon company, I told them to make me bimanual IA, which gives very good irrigation, and it is slightly only larger, and you should know the size of your zone. With the 1.1 incision, it's a snug fit. It's a snug fit. It doesn't leak. And the other one, every bimanual IA, if you take and then compare with your coaxial IA, the aspirating tip will be larger. I don't know why they make like that. And I told them to make it exactly 0.3, which is the size of your coaxial. So coaxial, that aspiration being larger makes the big difference, and the irrigating and the paracentesis ports leaking makes a big difference. Here, see, no change in chamber, no chamber fluctuation. So if no chamber fluctuation, everything is cool. Chamber fluctuation is the one which makes you scared, and then you may catch the capsule when you are going close to it. And irrigation, when I tried with this gives you, I got me around 75% of a coaxial irrigation. It will never come any close to the coaxial irrigation, but then 75% of the previous ones which I had, which were 20 gauge and all, they were giving 45, 60, maximum was 60, which I could get. So that irrigation may not be enough when you're aspirating very well, especially with larger aspirating ports. I have no financial interest in this, and I don't know whether they're making more of this. They gave me few, and after that I have not bought, and I don't know whether they're making or whether they have a number for that. So implanting an IOL, some IOLs will fly like this, and then it may hit any part of your capsule. See, a wrong method of 3-piece IOL being loaded with the haptic folded away from you. If the haptic folded towards the right, it will swing along, and while injecting, if you lose a lot of viscoelastic, then it will tear onto the posterior capsule. And I many times shoot these lenses very effectively into the bag, into the anterior chamber. See, this is all because of faulty injector tips. These are metal ones which can be reused multiple times, and they become straighter. They have to be at an angle so that it will slide along the optic. When it becomes straight, it will go over the optic, and then it will form a bottleneck. You can see it here. It is overriding the optic here. So then once it reaches a smallest, shortest width, you will need to generate a lot of force, and once it crosses that force will force the lens to fly into this one. So I catapulted the lens into the bag, and it is sticking there. It's not gone anywhere. So I thought I'll pull it back. Somehow there will be a piece around there in the periphery. Pupil is not that dilated. So just retract the haptics and place it away from the area where you think there is either a dialysis or a rent. But when this was in the PC and there is a rent. So I just retract and see. And using another thing, just curiosity, retracting and seeing, although it is going out, we have some more time, no?
Yes.
Yeah.
Yes,
so it is going out, and I go there and aspirate. Such a silly idiot I am, and I get vitreous. There was no need to go anywhere near that and aspirate, just for the sake of finding out what is happening. And now see the small piece which is there on top. And there unnecessarily I went and aspirated to take out all the viscoelastic and all. So don't be adventurous and too much nosy about all these things. Something wrong happens. If nothing is, you can visibly nothing is wrong, leave it and place the lens stably in another location and let some visco be there. Nothing will happen. I had to do finally a vitrectomy in this. So please learn from these silly mistakes which me at this age also make. So this is a mature cataract, a full rhexis. It is completely there. Just to make sure that the rhexis is completely there, I'm just showing you that the rhexis is complete. I finished the phaco, fill up the chamber, aspirate everything. Pupil comes down a little bit, and the chamber is not fully formed. This is a problem here. So this time it doesn't fly in, but then the bent tip goes little more into the bag, and now I see a fold here. See here, it was nothing wrong, just the lens into the bag and just a rotation. So I just failed to, I deny that there is a P-serent here. There could be some fold, there is cortex there, but still I realized that fold is not changing location, not changing position. It is extending from one end to the other, and it is an inferior P-serent. So I cannot leave a large P-serent like that with the lens haptic anywhere close to it, and it will decenter for sure sometimes, mostly, and especially because it is inferior. So I have to explant this. I have to dial it out of the bag and place. Do you want to see that? Place an IOL. No time, no, to show all those. So explant it. Place another IOL. Cut it. I should be showing that because that's not a that's not a bad thing to show.
Please do.
So So where is that? So this lens is dialed out into the anterior chamber, and a fresh another IOL, 3-piece IOL is placed into the sulcus under this lens. And that is all done with sodium hyaluronate filling up everything. And then this IOL is oriented in such a way that through the paracentesis I can hold the optic. And then I use a long tipped Vanna scissors which work for me in all lenses. I extend it 2.8 to a 3 to 3.2 so that it comes out very easily. There's no point in struggling to pull out these lenses, half of this lens through a small opening. Nothing. You're not going to gain anything. It is going to stretch the incision, and it is going to damage your incision. So this cutter is kept separately and not used in a regular case. It is kept separately and asked for when these kind of things happen. And there are fancy cutters, costly ones there. They do very well. But still, this also does very well for me, but it has to be a longer one, and do not use it for other purposes and make it blunt. It is made by Appasamy. I don't have any financial interests, I can tell you also. So you can also go and buy. So after this, this is in the sulcus, and because there is a mature cataract, the rhexis is slightly larger than 5.5, and anything less than 5 only an effective capture can happen, optic capture. This is optic captured. It is less than 5.5, but then otherwise, if it is more than 5.5, it won't get actively captured. It has to be less than 5. So this is another P-serent. Vitrectomy, I think in the previous talks they would have all talked about vitrectomy. I don't want to talk about vitrectomy. At the end, if you cannot see, I will put triamcinolone, because triamcinolone, I have seen it being repeatedly put and all those. It after a vitrectomy, it will just flow into the vitreous cavity, won't come out. And if you do not dilute it very much, it is going to stay there and cause intractable glaucoma and all those. So the retina people, they will curse you for putting all these. And after putting an IOL, if you want, you can construct a pupil and then put on top of it and see whether there's whatever this comes. I will not stop for the next 2 minutes more, 2 more minutes. So then this IOL goes into the sulcus. So the IOL goes into the sulcus, and here the rhexis is small enough. So watch carefully. I am going this in the sulcus, and I am going with a vitrector because a lot of visco has gone into the anterior vitreous space. I cannot just like that leave it there. That can again cause definite IOP rise. So although it is sodium hyaluronate, HPMC, sure, no. Don't take HPMC after you see a P-serent. Throw that down. Take only sodium hyaluronate. And then that comes out. When that is aspirated, some vitreous will also come. So use your vitrectomy probe. That will be the best thing to get everything out, most of it out, because a lot of visco vitreous, if you have cut, there is space for some visco also to be there. After this, you can manipulate with your second instrument, because some cases I have captured and there is a lot of visco behind, and it causes a lot of pressure inside, and you can't take it out also. So you can just nudge it out. See the second one in one part of the optic going under the rhexis margin. and the other part was also nudged under the rhexis margin. So this is locked for good. You don't have to change the IOL power. You don't have to be scared about decentration later. And the good thing is that this patient will not get a PCO. You don't have to yak this. But then after this, doing a vitrectomy, please see the periphery of the retina and then send them to retina clinic, because you would have aspirated. See, this is the last video of my trainee getting a PC rent in the nasal part, big PC rent. Rhexis is intact. So then we will start shaking, adrenaline problem, and then the decision making, everything is haywire. So the single piece IOL goes inside. It goes directly into the PC rent. I told her, stop, you get a forceps and hold. Took a Sinski. And with the Sinski trying to manipulate, instead of that, hitting the IOL, and IOL is keeping on going. So after some time, again she is going out and getting, she is just a she. So taking it out, and then it just drops. So it doesn't just like that drop. It will give you some minutes or seconds. By the time you should act. Before that it doesn't just fall. But remember, at the right time, take the right instrument and catch it, and bring it somewhere above the rim. So if you keep watching it, it will slowly fall into the vitreous in front of you. So training time, it is okay. But then once you are doing it alone, then it's very difficult to go and tell patient that you had very little support behind, and it went further behind, and somebody else has to come from behind and take it and all. Then they will tell you, why didn't you tell me all these things? You didn't tell me. You said nice cataract, you will do good cataract surgery and all those things. So very difficult to explain to patients when they have to be shifted, because when you have a big institute, they just have to be shifted from one OT to the other and get the VR person to get it out. But then other centers, it is difficult. Even if you shift, you can tell suddenly there is a current cut, or a machine has gone conked, some sound you make, quang sounds. So now we'll go to a different room and do the rest of the surgery. Don't worry and all. So that way you may escape.